Right, so surgical management of NEC. So this is a baby with NEC, obviously. They've got a big horrible tummy. They've got umbilical discoloration, which is really sensitive actually in babies of trouble. You can see they've got bruising in their flanks, so they got the full complement of everything horrible, and they've got some blood in the nappy. So this is a pretty bad tummy. And that was that baby's x-ray actually. And like, I guess you've all done neonates of some description. I'm talking at or to, but this is an x-ray that I got for you because it really does show pneumatosis. So you can, I don't know if you can see my little cursor, you might not be able to. But on the right hand side of the screen you can see what's called pneumatosis, and it's actually air in the bowel wall. And actually, you actually get air in the bowel wall. So this is what you're seeing on the x-ray. You don't often see it so beautifully, but you can see these bubbles of air in the bowel wall. And this is pretty horrible bowel. This is NEC. This is what it looks like operatively. This little pink little sausage down here is sort of normal looking bowel. There's a little chat can see. Excellent, good. And this stuff is white, it's dead, and it needs chopping out. So I guess the aims of this talk were to sort of talk to you about some of the decision making behind what we do with NEC, some of the operative strategies that you'll see employed. You know, why have they come back from theatre with bleh, this happened to them, or why is there a difference between this baby and the last baby? A little about outcomes with NEC, which will be super depressing, which is great for COVID, so I hope you've all got a drink. So we all know about modified Bell staging. Ignore Bell stage 1, it's not anything that is NEC, it's just sepsis, and ignore that. So we're talking about babies who have, you know, pneumatosis, things that you can see on an x-ray, signs of a systemic response to being unwell, and then you've got varying stages of disaster. Is it useful? I mean, people use it to report cases. Is it useful if you're trying to refer babies? It isn't, is it? I mean, the things that we're worried about are to do with how long it's been going on for, whether there's free air. We want to know about platelet count. We want to know about the baby's response to medical treatment. So actually, modified Bell staging isn't very useful clinically. So why do we intervene? Do you know what? You're not just going to listen. If you don't want to talk to me, you can chat as to what are the reasons that we'll intervene for babies with NEC. You talk. I'm drinking my beer. Perforation, definitely. That is an absolute indication to intervene. Okay. Any other indications to intervene? You're a shy lot, aren't you? Like, I'm here, out on a limb, drinking beer, talking to you, and you are not talking to me. It's so sad. Hang on, wait, chats are coming through. Woo! Failure to respond to medical management. And I think those are the other two. So it's failure to respond to medical, and that's absolutely true. And so these are babies in whom you've started NEC treatment, you maybe transfer them to a surgical centre, or you haven't quite transferred to the surgical centre, and you see what happens. And it's usually pretty obvious. The babies are either going to get better or they won't, and that period of time is a couple of days. There are some markers and really interesting things which are good predictors of whether you're going to fail medical management. And one of the things that's not written in any textbooks, but which I'm going to tell you a secret because you're also chatty and you're my friends tonight, is that if you still see pneumatosis on an x-ray 48 hours after you initially see it, that's a pretty good sign that the bowel is dead. Okay, so persistent pneumatosis is really important. People talk about things like fix loops or and all that stuff. I don't quite understand what that is, and I never quite have. But deterioration in the face of maximal intervention, a persistent mass or obstruction. So actually what can happen is the babies can get better, but actually they form an inflammatory mass around whatever's happened. They get a little abscess, or finally they can get obstructed. So those are our indications to intervene. These are the things which people have done studies saying how specific and sensitive the chances of you getting an operation. Obviously, if you get pneumatosis, someone did some studies, looked at paracentesis, sticking needles in babies. I mean, that's totally ridiculous. M says, so would you have a pneumoperitoneum and it self-resolve? Well, that's a really interesting thing, M, who doesn't want to talk to me because they don't want to go on the microphone, which is very sad. M, do you want to mute your microphone? Talk about this? M, nothing. Coward. Okay, it is possible to get something called a spontaneous intestinal perforation, which is babies, little tiny babies who get a perforation. Someone does an x-ray in the middle of the night. There's definitely free air on the x-ray, and the next day the baby's absolutely fine, and it's sealed itself. And there are a small number of babies who have what's called spontaneous intestinal perforation. They don't seem to get massive systemic upset from it. And pathologically, it looks completely different. Like all the bowels normal apart from this little bit with a hole in it. Is it NEC? People have tried to distinguish between that and NEC, and it's probably part of the same spectrum, but who knows? So yes, in answer to your question, M, who won't talk to me, who's going to run off at some point, it is possible to get a perforation, and it can seal, and so you can see a baby who's had an x-ray before, and then they're all better. I'll come back to perforations in a minute, because that's those babies with what's called SIP are probably important in terms of, oh look, you can see me, that smells so good. Okay, it's better. I look like I was in the dark in dungeon. Okay, so a little bit about operative intervention. I kind of want to talk to you a little bit about what's going to dictate what management we do. Some of it's to do with the disease, and some of it is actually to do with the baby. Okay, so disease distribution. Of all the babies who get an operation, about half will have patchy involvement of the small and large bowel. Okay, so it tends to be a disease which is kind of everywhere, but it doesn't affect everything. A small number will have an isolated small bowel segment which is involved, so you can kind of imagine that that might have been a thrombotic event, that actually you can take out a little arcade in the bowel. Some babies have pan-intestinal NEC, and these babies, I think they're quite easy to predict which of these babies these are going to have pan-intestinal NEC. This is the baby who is IEGR, born at 400 grams, has always had a distended abdomen, never been quite right, and then minding their own business in SCBU at 31 weeks of age, and then suddenly falls in a pile, massively acidotic, metabolic acidosis. You will have seen babies like this. And there's something about that disease process which is different to regular NEC. Pan-intestinal gangrene is just kind of worsened version of NEC. The principles of the management are pretty simple, actually, and NEC surgery is very easy. Like I could teach any of you how to do it. It's not difficult at all. Okay, what we are trying to do is we're trying to manage sepsis, so we're trying to remove bubbles from the peritoneal cavity to allow the antibiotics to work. We're trying to remove as little bowel as we possibly can, and I've said mind the liver. Pretty much the only thing that's going to cause babies to die on the table, apart from those who have got pan-intestinal NEC, is causing a bleed in the liver. Now, the liver in babies, any of you been to theatre? Babies who've been operated on? It's such a chatty bunch. Nothing. Oh, wait, there's a chat. Woo! Yes, JU. Thanks, JU. the liver occupies a massive amount of space in the baby's abdomen, and it often comes down below the level of the umbilicus. And the liver is then tense, it's full of fluid, the babies are coagulopathic, they have low platelet counts. If you touch the liver, if you pull the liver in the wrong way, if you look at it funny, it will start bleeding. And if it starts bleeding, it won't stop bleeding and they will die. So babies who die from bleeding, it's bleeding from the liver. So there's stuff about stomas versus anastomosis. You all worked at different places. If you worked at surgical centres, some babies come back with stomas. Some centres prefer to do a primary anastomosis. What's the evidence for it? Actually, there probably isn't very much evidence to support either approach in preference to another. So it tends to be a unit-based approach. There's never been a randomized control trial about it. And there's something about which patients you're going to do it in. Now, if you've got a baby who is dying in front of you, trying to do an anastomosis, which is going to take you 20 minutes on a good occasion, or a stoma, which is going to take you 5 minutes, you're going to do the stoma. The people who are pro-stoma will say that this is a really easy thing to do. It gets you out of trouble, and it gets the baby back to the intensive care unit or back into the incubator if you're on the intensive care unit. So that's why you would do a stoma or an anastomosis. These are different sorts of stomas. Do we care? Probably you don't care. Babies can have stomas where the functional end and the mucous fistula, so the osteoid and the mucous fistula, can either be next to each other, can be separated apart in the wound, and people do all sorts of crazy things with them. Some babies, the bowel, distal bowel is really, really sick looking, and we end up bringing up a very high stoma. These are high jejunostomies. These babies can't establish enteral feeding, and we really worry about these babies' livers and want to be thinking about closing them very early. And we can put it in the wound or away from the wound, and there are various pros and cons to that, and you don't need to know about that because you're pediatricians. How am I doing? It is. Are we okay? Are we going too fast? Are we going too slow? Hang on a second, we got questions. Woo! Go team. Huang Yang says, how do you decide whether to clip and drop the distal end or bring it out as a mucous fistula? That is a really interesting question. And the answer is, some of it's about surgeon preference. If you bring it out as a mucous fistula, when you come back to close the stoma together, you've got your two ends up by the skin. So actually all you need to do is to dissect those two ends and join them together. In theory, it makes it an easier operation because you don't have to go fishing for the other end. That's why we bring out a mucous fistula. Some centres, and I don't know if you work at King's, maybe, or south of the river. Anyone ever been south of the river? Don't go there, it's very dangerous. Someone south of the river. So Kings, they like refeeding. If they have a high stoma, they feed into the bowel. So some people use the mucous fistula to refeed what comes out of the stoma to put down to keep the bowel healthy. So those are the reasons why you might have a mucous fistula. JU says, what is your personal experience of primary leaks? JU, I've never had an anastomotic leak. How very dare you? No, I'm only joking. I do very few primary anastomoses for NEC, and the reason for that is it is an appropriate thing for the thing that we talked called SIP, spontaneous intestinal perforation, where all the rest of the bowel is relatively healthy and the baby is relatively healthy. In order for the ends of your bowel to join together, we put a row of stitches around, but actually what you want is good vascularity, a nice healthy immune system which is going to allow the bowel to heal, and hemodynamic stability, and all the things you don't have in NEC. Now, you can do it, but I would argue that in the context of someone who is very sick, doing a stoma and coming back in 2 weeks' time, it's safe to do a primary anastomosis in the majority of patients. Someone got bored and left, probably without asking a question. Alice K says, doing good. Thanks, Alice. You're doing great as well. It's not good if I can't see anyone, is it, Katie? Like, you're the only one who's playing. Boring, the rest of you. Kwang Yang Li says, what is damage control laparotomy? Kwang, that is a fascinating question. That is a concept. Damage control surgery is something that we talk about in terms of trauma. So I work at St Mary's, which is a major trauma center. We do quite a lot of damage control surgery. And the idea of damage control surgery is this okay if we talk about trauma for a second, everyone? Katie, you're the only one I can see. Give me a little thumbs up if you're happy. Okay, in the context of trauma surgery, the idea is you have a very sick patient who is dying in front of you, which is pretty much what some of these babies with NEC are. If you are in theatre for a prolonged period of time, what will happen is you will get this triad, which is a triad of misery or death or whatever you want to call it, of hypothermia, coagulopathy, and worsening acidosis. And they all feed into, that's not really a triangle, is it? They all feed into each other and they all spiral. And damage control surgery is the idea of taking your person who's critically injured, or in the case of NEC surgery, this baby who is dying in front of you, you go in, you do the absolute bare minimum to stop them from dying there and then. So for a baby with NEC, that is chop out the thing which is absolutely dead, put some clips on it and drop it all back in again. You probably don't close the abdomen as well. Okay, and principles apply in trauma surgery. In trauma surgery, you've just been stabbed in the abdomen, which is like a good way to greet yourselves in some parts of northwest London. You go in, you big incision down the middle, pack the abdomen, stop whatever is bleeding, you know, take out a spleen if it's smashed to pieces, repair the aorta, but that's all you do. You don't fix everything. If you've got a hole in the bowel, you put clips on it. You don't close the abdomen. And the idea is you get them back to intensive care, stabilize all the things which are going off, which are killing them, and then bring them back in 42 hours later. There's a guy called Errol, who's a pediatric surgeon in Birmingham, who's also an army surgeon, and he's sort of written a paper about this, and he wrote another paper actually recently. I hope that answers your question, Quang. Another question, how long do you usually wait until attempting to rejoin and close a stoma? The answer is, it's a bit of a tricky one, and it's something where there are some people who think we should close them very early, and I'm in that camp. And there are some people who are a bit more laissez-faire and feel like what you have is you have a baby who, unless you've got a very distal stoma right by the terminal ileum, you're not going to absorb enough feeds to grow. So you're going to end up on PN, and if you end up on PN, you end up with liver dysfunction, and if you're really unlucky, you'll end up with liver failure. And I think closing them early and almost closing them with a planned date as soon as you do your original operation is the right thing to do. There are some centers that don't do that, and I think there's a bit of work going on around trying to standardize that a little bit. Okay, so I would always advocate for early closure and also planned closure. So if I do a stoma, I usually give a date for when the stoma is going to be closed. How much bowel do you need to be independent, says Alice K. Alice, are you there, Alice? She's not going to answer me, is she, Katie? Okay. So the absolute numbers are nonsense. Okay, so people talk about 50 centimeters valve or 25 centimeters. It's total nonsense. This is a historical thing. I think if you've got less than 20 small bowel and you've got no colon, the chances of getting off PN are pretty low. However, you have a meter of small bowel, and if it doesn't peristalse and it's dilated and baggy and just sits there, you will be PN dependent. And you can have babies who have meters of small bowel in their colon and get off PN. So it is about the bowel, I think will probably be the best way to answer your question, if that's all right. JU says, don't be offended, we're all at home and look like crap. And that is my problem. Like, I look like crap. Look at this hair. Look how much hair there is there. Look, I'm drinking a beer. This is supposed to be relaxed. That's all right. I don't take offense. I'm just trying to make this entertaining for you because you are at home and it's been a pretty boring time with COVID, everyone fatigue, and it's all a bit depressing. So I'm trying to make this really, really depressing subject, which your colleague chose, a bit more upbeat. Okay. Sidi asks, is NEC a surgical diagnosis, a medical diagnosis, or a pathology? Sidi, NEC, strictly speaking, is a pathological diagnosis, but I think if you've got pneumatosis, you've got NEC. So I think you can absolutely say that a baby has NEC if they've got pneumatosis. As far as everything else, you know, the constellation of symptoms, that can be sepsis. But, and surgically, you can definitely make a diagnosis surgically. Okay. Could be SIP as well. So SIP, you don't get pneumatosis. So we came back to SIP, spontaneous internal perforation. You do not get pneumatosis. You get a perforation all of a sudden out of the blue in a relatively well baby. You don't get a prodromal illness. You don't get massive problems. You do get respiratory problems because you fill up the belly with air. So they will end up being ventilated, but they don't have the coagulopathy, often their lactate's pretty normal actually as well. Okay, so sleep. Good. Okay. Everyone okay? We detoured into trauma surgery. We're back onto NEC. Or should we do something completely different? Carry on? Okay, I'll carry on. So the problems with stomas are the output, particularly if you've got a high digenostomy, the output is high, so you lose lots of fluid. You also lose lots of electrolytes, and you generally, it's all a bit miserable. Skin care becomes a problem because the stuff that comes out is pretty toxic to the skin, and babies get skin breakdown, and enteral feeding is a problem. We need to enterally feed. Your enterocytes only get their nutrition from the luminal contents. They need glutamine to be healthy enterocytes. If you don't feed your gut, then you get villus atrophy, which is what we all learned at medical school, and it's true. Closure. Oh yeah, we talked about closure. We said we were going to close them early. We always do a contrast study if you can distally, and that's to plan your surgery. So you're looking for strictures. Stricture formation. Most of the papers overquote the risk of stricture formation, like 30%, 40%. The risk is probably about 10%, and it's pretty predictable, actually. You can usually tell the baby you're going to get strictures because you usually know what you've left behind. Yeah, so 10 to 50% higher in the operative group. So pan NEC, the babies who are incredibly sick, get incredibly sick incredibly quickly. And the answer is that they're a real problem, and they're a real problem because it's more to do with the decision making of you've gone quickly, and the parents have obviously often been transferred to a surgical unit with their baby and expecting something to happen, and actually when they do operation you find that all of the battle's affected. So you can try and temporize them with that high stoma. You can withdraw. That's really difficult to do unless it's really, really pissed. And so most of them with really bad NEC will end up having a second look at about 48 to 72 hours to make some prognostic decision making. Does that really affect anything? The answer is it probably doesn't. But what it does do is it gives the parents time to process. Essentially what you're saying is that this baby is going to die and has something which is not compatible with life. And sometimes that's a really difficult discussion to have with some of these parents. And it's why I don't particularly like neonatal surgery. I said it. I know I'm a pediatric surgeon who doesn't like neonatal surgery. JU says, what do you consider an acceptable stoma output from a high stoma? JU, people go for about 20 mils per kilo before they start replacing. The high output from the high stoma, you're kind of almost expecting it from some of the stomas. so you just accept whatever's coming out. But I think when you're trying to feed the baby, you're trying to get the bowel a little bit healthier, or trying to give them at least some enteral nutrition to protect their liver, sometimes you find the stomas just pouring out, producing 700, 800 mils a day, and then that's unacceptable. And that makes you think about doing it earlier. Asks, do you tend to use loperamide in baby with high stoma losses? You can do. It probably works. But I think you should close them early. Actually, use babies with a high stoma losses. Clip and drop. Someone talked about clip and drop. So when you've got lots and lots and lots of disease, you don't have to do a stoma. You don't have to do. You can just chop the ends that. Ooh, what happened there? Chop the ends which are sick looking, and leave a whole bunch of sausages to come back and join up in 4 to 6 weeks' time. So you're going to say that this baby's going to have high aspirates because they've got nowhere for the stomach to empty, and you accept that they're going to have a funny looking belly, and you accept that you're going to give them PN. Peritoneal drains. Who mentioned SIP to begin with? Somebody did. Let's see. Somebody said something. Can you have an M if M's still there? I said we'd come back to SIP. In the 2000s, or we're in the 2020s now. In about the 2000s, people started to get excited about drains. And the fact that if you got a perforation, if you stuck a drain in, some of the babies seemed to get better. And those babies had SIP. They have a tiny little area with a tiny little hole in it. You drain their abdomen, you ventilate them, and they get better. Magic. People then said, right, well, we think we could just put drains in our studies. And there were 2 randomized controlled trials which ran pretty much at the same time. One run by Larry Moss in America, and one run by Agostino Piero, which was a European one. And they both had slightly different criteria for who was going to get randomized to drain or surgery. So you couldn't really do a meta-analysis. Neither of them was powered to detect a significant difference. I think what the conclusion of these 2 randomized control trials is that they are a useful temporizing measure. And actually, if you put a drain in, all you're doing is delaying going to theatre. So from an NTS perspective, if you are NTS people or do any transport stuff, actually it is a temporizing measure. If it's so tense from free air, then putting a drain in, putting a cannula in, putting a finger or a glove in, putting something in, allow you to vent the baby slightly less hypoxic and less acidotic, is beneficial to get you to a surgical center, but you're not going to prevent them having an operation. Unless you're lucky enough to find the baby with SIP, which are pretty rare. One of the graphs from one of those papers, and basically what it said was, if you had a peritoneal drain, if you had a laparotomy, everyone portion surviving. So drains didn't do anything useful. Katie, are you bored? Okay. 35 minutes of boring NEC. I told you this was boring. I told your colleague NEC was terrible, terrible topic to put your people through. All right. Outcomes from NEC. Our mortality from surgical NEC at 30 to 50% probably, and it's unchanged. So nothing natal care, special surgery. Our mortality, if you end up having surgery from NEC, is about the same as it was 20 years ago. That's depressing. Short bowel. The registry have a lot of babies in NEC who end up being on the long-term TPN registry. Hang on, woo, Sudeep says, can you put a drain in unstable neonate, come back and operate? Is that useful as part of your experience? It is not, Sudeep. If you're in a centre where you can operate. If they're not stable enough to go to theatre, you do it on the unit. If you put a drain in, you're just delaying your operation. And if you're in a place where you can operate, you should operate. There you go. That's my view on that. I'm sure other people have other views. I should have kind of preceded this all by, these are personal views. Thanks, Sudeep. This is data history, and you can see that at 2 years following the first PN, NEC are quite a big group of these babies. So gastroschisis, but NEC, they do end up long-term PN. It is a bit miserable. And so you might ask, what are we doing? The final thing, which is really great fun, even if your neurodevelopmental outcomes, if you've had surgical NEC, are totally terrible. Okay, so having surgical NEC compared to medical NEC, so compared to other babies who didn't have NEC, NEC babies were smaller and neurodevelopmentally, and had much worse neurodevelopmental outcomes. I'm going through this all because it's just so depressing. And there's another depressing table which is even worse. Like terrible NEC gives you terrible cerebral palsy. And pretty much most of the babies with really bad cerebral palsy now had NEC as neonates. You guys are really smart, and with your cooling and everything, you've managed to solve the HIE cerebral palsy, but NEC cerebral palsy is terrible. Stupid question, says BR. It's unlikely, BR, given the content that I've given you this evening, most of this has been pretty stupid. How do you differentiate between NEC and aseptic ileus? BR, that's an excellent question. And the answer is, and I hope we've covered it, if you have pneumatosis, you have NEC. If you have a distended abdomen and you're not very well, then you might just have ileus. So you need the pneumatosis, you need the blood in the stool, you need the kind of everything else. Otherwise, it can just be sepsis. Katie says, do you know why the terrible neurodevelopmental outcomes? Is it a common etiology for both or NEC? What do you think, Katie?
I don't, is it because these are the small? Okay.
Yeah. So no, go on, Katie. Go on. You're talking.
I was gonna say, are these like the small, sick, like deprived babies already, and they're gonna get all a host of problems, or is it like the NEC and subsequent trauma of that causes the developmental outcomes?
So that the assumption is that the cerebral palsy, the neuron getting, is the brain's hit of this multi-system disease. I think the thing that NEC is a gut manifestation of whatever it was. So we think in ischemia reperfusion event, yeah, ischemia reperfusion, bacterial translocation, and then mediators, which then damage everything else, that give you renal impairments, and the probably take so stuff floats around having had NEC. Also, I guess you're much more likely to have been hypertensive, inotropes, big changes in blood pressure, and I think the things which give you NEC are the things that give you a bad brain. Quang says this is an association, not causation. Yeah, I think of the brain as the end organ, as an end organ effect of this horrible inflammatory process. And I think that's probably the best way to look at it. Oh, I lost you all. Sorry, Greg, can you hear me now? Says, sorry, I lost everything. Greg says, Greg was asking about term NEC. NEC kettle of fish. Has anyone ever seen term NEC? Yes, Sister Joshua. Good. Term NEC are really sick, like properly unwell, and then these are talking about babies who have gone home and come back through A&E with NEC, incredibly unwell. Is it the same disease process? Well, it probably can't be. It probably can't be. Or there is something which has led you to have your ischemia reperfusion, like a really bad cardiac lesion, which gives you your NEC. But term NEC is a bad thing. They usually end up with really bad multi-system disease, lots and lots of cardiovascular instability, and very sick. So, hope that answers that. CW says, pneumatosis versus meconium on an X-ray. Any tips to differentiate without restriction or follow-up? No. Yeah, I guess so. I mean, look at the bowel itself. I mean, I know the X-ray I showed you was pretty obvious in barn door. Does it matter? It probably doesn't matter that much, I think is probably the best thing to say. If you've got a baby who you suspect you've got any, you do an X-ray and you think there's a bit of pneumatosis, you are going to repeat that in 24 hours anyway. So it doesn't necessarily matter whether you can spot it or not. You're still going to antibiotics, you're still going to support them, you're still going to put them nose by mouth. So if you can't make the diagnosis of pneumatosis on an X-ray, a radiologist could next morning if it was in the middle of the night, but actually it shouldn't matter too much. I've been told he's born at term who developed NEC have worse outcomes. Yes, yeah, we said that, didn't we? Yeah. True, and why? Yeah, it is, because I think if you think about the things that hemodynamic instability, reverse tendile flow, you don't have things that, so if you think about it as a stepwise process, the things in order to knacker your bowel in order for gut to take place must be pretty bad, and that's the best way that I put it. Okay. So is it hopeless? Are we better at risk stratifying? I don't think we are, actually. I think we still transfer babies around between neonatal units because some surgeons won't give you an opinion on X-ray. Have any of you had that encounter? Transfer the baby, we're not going to give you an opinion on X-ray. Something like that. You have. You just don't have to fess up to it. I think you can predict who's going to do badly, actually, with experience. There are some other things that we can think about doing. There was a cooling study a while ago, which looks at NEC. We think this is an inflammatory process, so, and we think that damage is done by inflammation. So can we switch it off? You know, should we be thinking about immunomodulatory drugs? Should we be thinking about things to switch off IL-6, like anakinra? Oh my goodness, that's IL. But it's tocilizumab, but that's all being used up by COVID patients. But I think we need to be thinking a little bit differently about NEC, and if we think this is an immune-driven phenomenon, can we switch the immune system off? JU said yes. I don't know what JU said yes to, but thanks, JU. So that's it. That's all I had to say. Oh, that was hard work. I haven't even drunk on my beer. Any questions? Anything I should like 8? There should be more attendees. Come back and present something else. Whoever M is. Is that M as in like James Bond? No, I'd love to. If you guys tell me what you'd like, I'm really happy to do these. It doesn't take very long to rustle up something, and we can talk about Chlorosinosis, the pain, troublesome constipation, other neonatal stuff. I hate neonatal stuff, but we could do other neonatal if you want. Fetal medicine counseling, anything you want. Okay.
Hello?
Right. I don't know. Hello? What was that?
I have a question.
You said hello? Oh, me. Woo. Hi. TY.
Hi. I just want to ask, in the first picture you saw of from the surgery of the bowel, was anything solvable, or you had to remove all this?
So all the while, actually, in the decision-making process when you're actually operating, often it's pretty easy. There's either stuff which is frankly dead, and that comes out. There's stuff which is frankly healthy, and that's fine as well. And then sometimes you get stuff which you're not quite sure whether it's alive or dead, and in which case you just leave it in. So the idea is, the principles are, you preserve as much length as you can. If you think something might survive, leave it in, and you come back another day and fish it all out. Join it. It's terribly easy. Like surgery in babies is not difficult. You could all do it. This is not difficult.
Do you prefer to save some bowel and return to do another surgery rather than remove a potentially healthy bowel?
Yeah, and I think that's the principle of surgery of NEC, which is to maintain length. We know length is important, and I know I answered someone's question by saying sometimes you have a long length of bowel and it doesn't function, but actually, you know, length is important. You know, if you can preserve more length, if you end up with 75 versus 60%, you assume they're going to do better, but it's not an accurate picture to say that length is the most important thing.
Thank you.
Okay, does that answer your question? Oh, thanks for talking to me as well. There's a baby. Hi, baby.